どレクチャーを始めたいと思います。一応、先生のご略歴をですね、簡単に説明します。ダリワル先生はですね、1994年にノースウェスタン大学の経営大学ですね、そちらを出られて、1998年に同大学の医学部を卒業されて、その後 UCSF の方で、レジデンスを送られて、2001年に、チーフレジデンス、2001年というとですね、それが月の先生がチーフをやってた時代になります。その後は UCSF のですね、VA 医療センターというところで、いろいろ仕事されてですね、現在2010年からは、准教授という形で、お仕事されています。代々内科のチーフをあるとですね、UCSF の先生が行って、研修されてもらうという形になって、私とか、木野先生としています。いろいろ賞を取られて、毎年のですね、ティーチングアワードということで、それに対する賞をですね、毎年、本当に連覇してですね、10年ぐらいずっと見てると取ってらっしゃるんですね。それぐらい非常にそのティーチングにですね、情熱をかけてらっしゃる先生なので、非常に分かりやすくですね、講義していただけると思いますので、どんどん質問してフランクに話したり、楽しいレクチャーをしたいと思います。よろしくお願いします。
こんにちは。Good afternoon. I am Dr.Dhaliwal from University of California, San Francisco. Dr. Ohei gave me a very nice lecture. This is my 5th time Chigasaki, right? 2008, 2009, 2010, 2011, 2012. I love Chigasaki. I enjoy it very much. So we will do teaching on Tuesday, Wednesday, Thursday, Friday. Friday I'll take airplane back. So I am a GIM doctor, general internal medicine doctor. At my university, I do medical student teaching and internal medicine resident teaching. So general internal medicine, so I do every topic, brain, kidney, lung, skin, everything. So we will have different discussions each day. And I also work in the hospital, in clinic, and emergency room. So I work 3 places. I ask, usually I will do writing on board, not too much PowerPoint, but then I will ask you many questions. I will ask people questions. It's okay. If you don't know answer, it's okay. If you don't know my English, I speak slow, but if you need Japanese translation, please ask. We will do Japanese. So today's topic, we'll start with brain. Today we'll do altered mental status, confusion. So, and I will write on board here. So, patient altered mental status is very common complaint. Every specialist must know. It's most common we see in elderly. So if you see elderly patient, we see altered mental status more. But I want you to think of acute altered mental status is like acute brain failure. We say acute kidney failure, acute heart failure. I want you to have this concept. It's like acute brain failure because brain stops working. Doctor has to figure out how come. What is the etiology behind this? Before we know patient is acute, we must make a decision which category patient is in. So there's 4 big categories, then 4 acute categories. So I'll give you 4 categories. Is it hot? Room is warm? Turn down the temperature. Good. Because if I keep temperature high, then resident has acute brain failure. Everybody falls asleep. So if patient comes to clinic, comes to emergency room and is altered, sometimes you know acute, but sometimes maybe chronic. We don't know. So first question is, patient has dementia, or delirium. This one equals AMS. or sometimes psychiatric, we must determine. Okay, so some delirium. Okay. Who can tell me difference, a little bit difficult, difference between dementia and delirium? Who knows difference? What is the difference between dementia and delirium? Do you know? In Japanese? Right? The distinction, dementia versus delirium. What is difference? Yeah. Yes? Does not come to normal. Good. So delirium, if you have concept, is patient is chronic. It's chronic problem. It is chronic problem. Never return to normal. And usually has problem with memory. Memory is big, so chronic problem patient has with memory or with function. The thinking function, chronic problem. This is dementia. So what is some type of dementia? Give some examples. Common dementia. Alzheimer's. So most common, probably the whole world, is the Alzheimer's dementia. And maybe one other one is common. One or two other? Vascular dementia. Very good. So I think most common, this patient has cardiovascular disease and vascular dementia. Old name is multi-infarct dementia. Because multiple infarcts, multiple small brain infarct. They say multi-infarct dementia. But now we change. Now they say vascular dementia. So two types of dementia. Psychiatric is always possibility. So always must consider maybe schizophrenia, maybe severe depression, maybe severe anxiety. This is separate lecture. If we have psychiatric lecture, then you must learn each one individually. But these are common diseases. In general, internists must recognize schizophrenia, severe depression, anxiety together. Okay, but today's lecture is delirium. This is concentration, so we focus this one. And if you open a textbook, you have, maybe does everybody have book? If you look at book, for acute mental status, this long list, many problems, everything is on the list. But it's too difficult, you can't remember a long list. So we must say, maybe we have some idea. Give me some idea, some diagnosis that causes acute mental status. Give me some ideas. Maybe diagnosis, how come old person has altered mental status? Can anyone give suggestion? Give me one example of how come old person has altered mental status. Probably like that. So drug abuse, it can be prescription medication or illegal or drug abuse, right? So that's one category. Other idea, how come patient comes to emergency room with altered mental status? Other idea. Alcohol, yeah, the drug or alcohol, yeah. It's very common, it's true. Electrolyte problem, yeah, so electrolyte we think about. Do you know which electrolytes? Yeah, but two common ones, sodium and calcium. So sodium, calcium, because potassium no, magnesium no, chloride no, but sodium and calcium, if they are very high, and if sodium is low, cause altered mental status. So we're having ideas. One more idea? What's that? Fever, how come, what type of fever though? What causes fevers? So there's a meningitis. So I will give you four categories, and then we'll put example inside, okay? Because very good ideas. Drug, alcohol, fever, meningitis, electrolyte, all is important. But your brain must organize, must have some organizing. So take altered mental status. I will tell you there are four categories. Four for acute altered mental status. One is metabolic complication. Second is infection. Number three is structure. Structure means inside, brain structure, inside brain. Number four is toxin. So alcohol, drug, something. So take a look, this is very important. This is how I teach my student or my resident about altered mental status. I say, don't remember long lists, because you don't need these days. You can look up lists on phone, right? No need to memorize long lists. But you must know big categories. I teach also in, this does not work in Japanese, but in English, if you take M-I-S-T is a mist. Mist is a, maybe someone can do Japanese translation, but mist means like foggy or hazy. And then what is Japanese word? Foggy, hazy? Kiri, okay, kiri. This in English is like kiri. So same, brain is not so I also teach my residents, remember, M-I-S-T. K, like this? Like this? No. Like a kitty. So same concept, brain is a little foggy. So each one has certain etiologies, and each category has certain tests. This is why this is good. Doctor cares about list, but doctor has to learn which test to order to make diagnosis. If history and physical exam does not give you idea, very frequent for AMS, you must do extra testing. So metabolic, we have some idea. We have sodium, high or low, calcium. Infection, there are two types of infection. CNS infection, non-CNS. Okay. So CNS infection, you gave me example, meningitis, excellent. Toxin, people have good example, they have drug abuse, alcohol abuse. Okay, give me some other example. Give me a different metabolic problem, different infection problem. This old person, how come they might be confused? There are many more we have to fill. What are other reasons older patient may have confusion? Idea? What's it? Uremia. Very good. So uremia is metabolic problem. If patient has uremic problem, so if they have renal failure, acute kidney injury, then uremia. Which is another organ. If it has organ failure, patient becomes confused. Kidney failure and liver failure. So hepatic encephalopathy or uremic encephalopathy. Very good. Okay. Then give me another example. Maybe some endocrinology problem. Metabolic also is endocrinology. How come?
Hypoglycemia.
Hypoglycemia, very good. So sugar in both directions, high or low, either. So glucose, high or low. And maybe one other hormone. which other hormone? Patient becomes very tired, very sleepy. Thyroid. So thyroid, thank you. So thyroid problems. You sometimes high, but mostly low. Thyroid, okay. So here's good list. Here's metabolic list. So for this one, you must do. This is like dialog box on iPhone, no? You must do blood test. These are blood tests you must do. Because physical exam is very difficult to pick up. Maybe encephalopathy, if you have asterixis, is possible. Thyroid too, thyroid has physical exam finding. Other ones are a little difficult. What are some physical exam finding? Hypothyroid. Patient has low thyroid. What is physical exam findings for this patient? Anyone? Has anybody seen a patient with low thyroid? A young doctor, Dr. Hoy, of course. I expect. Anyone else has seen low thyroid? Maybe you have read in book. What does patient look like? Skinny or fat? Fat, a little bit swelling. How about neck? Neck is normal size, swollen. Swollen. If they have goiter, then it might be swollen. Okay. How about reflexes? Slow. Slow. We say hung reflex. So it goes like this, and then stay in the air. Like you can see the back. No. Like this. So physical exam can help with metabolic, but very frequently you need blood testing. I also say one other thing you must think about with metabolic, but you must do then ABG, is oxygen and CO2. Because sometimes metabolic problem may be respiratory in origin. So if the patient has low O2 or high PCO2. It is very interesting physical exam finding. Maybe Dr. Ohe, you have probably seen respiratory failure. Sometimes patient has asterixis also from high PCO2. You have seen things? So if kidney fails, in book teaches hepatic encephalopathy, asterixis. You know this? Yes, this is asterixis. But patient with uremia also can have asterixis, and patient with high PCO2. Maybe before intubation or if on edge, they put out hand, they have same asterixis. So if organ. Okay, so very good. So for metabolic, we must do blood test and must do ABG. And let's change. Infection. Please tell me which infections can happen inside CNS. CNS infection. One, meningitis, which is other. If brain is infected, what name do we give? Encephalitis. It's important in young patients. I have seen here in Chigasaki over 2 years, interesting case of young patient with altered mental status is encephalitis. We had many years ago in ICU, I remember. So encephalitis also. Okay. But much more common in old patients, much more common in old patient outside CNS. Infection is not inside CNS. Infection is outside. What is the common infection? Old woman, old man becomes confused because of what infection?
Laryngitis.
It can be cholangitis, but usually it's not too, then they may have atypical presentation. So I would say some GI, biliary, yep. But which is even more common in old patients? Pneumonia, and one other one. UTI, yes. So you should, if you are a doctor and you see a patient with confusion, you should ask, confusion plus fever, textbook says meningitis, but real practice, usually pneumonia or UTI. So you must understand that if patient has fever and confusion, an older patient, often this one. Younger patient, you must think a little more. Then, if young patient gets UTI, 30-year-old, 40-year-old patient, they do not have confusion usually. Or if young patient has pneumonia, usually they do not have confusion. So if it's young patient, more likely this one in fever, and older patient, more likely this one. Okay, it's very important concept because You may do jolt sign, neck stiffness, everything, but you really need UA. You must do UA for UTI or chest X-ray physical exam for pneumonia. So this one, what is test? The important test is chest X-ray, UA, and then plus minus LP, lumbar puncture. Because for meningitis or encephalitis, you must do LP. So 3 tests in infection category to think about. Okay. Structure means problem inside brain. What are some problems that might happen inside the brain? Outcome patient may become confused. Young patient, old patient, what can happen to the brain? So stroke, good. Stroke can happen. What else? How else can patient have confusion? If you do CT scan and positive because of what? What thing? Hemorrhage, so ICH, intracranial hemorrhage, very good. So ischemic stroke, ICH, how come, what else? Old person fall, yesterday I was at Mito Hospital, old man, he fell down 7 days ago, hit his head, and today he is confused, 7 days later, how come? What was diagnosis? Yeah, yes. What's this?
Chronic subdural
Perfect.
hematoma.
Subdural hematoma, yes. You can tell by history. 7-day fell, hit head, then slowly more confused, slowly as subdural hematoma. Good. So you have this one. And maybe one other possibility, young person, maybe more, but also you must think of maybe brain tumor. Sometimes brain tumor has chronic headache, but then acute AMS. So structure problem needs to have, example, is maybe ICH, maybe ischemic stroke, maybe subdural hematoma, maybe tumor. So this one you must do neurologic exam, but then testing. Testing is CT or MRI. And then toxin is, we said this one, illegal drug maybe, too much alcohol, maybe even residents sometimes has partied, too much alcohol, it's altered mental status, it is possible. And then we must remember our drugs, medication doctor gives too, so medication is a big problem. Please give me some example of medication doctor gives that may cause confusion. What are some examples? Which medication doctor gives that may cause confusion? So many, so we can think of some examples. Any idea?
Benzodiazepine.
Benzodiazepine, very common. Benzodiazepines, which else? Maybe number one problem, benzodiazepine, yeah. Which other ones give confusion? Because you must, if you see medication list, your eye must be able to detect. Because maybe they don't need long history physical, maybe only benzodiazepine or something else. What are other examples? Okay, if you don't know, we'll take a 2-minute break. You turn to your neighbor. Everybody discuss with your neighbor. Think of 2 medications that cause AMS. Okay, talk. Talk to your neighbor. Oh, this would copia. That's a sleeping jet lag. No,
You still have your jet lag.
no, I think usually I've been here 4 days now.
When I went to San Diego, I had the jet lag.
Yeah, it's horrible.
It was 1 week.
Because I think you have to wake up very early.
Yes.
That's the problem. Okay. So now you have some discussion with your colleagues. Please tell me some idea which medication caused altered mental status. Benzodiazepine, yes. Give me other examples. Yes, sir.
Major tranquilizer.
The tranquilizer, yes. Benzodiazepine is like tranquilizer. Yes, tranquilizer does. Yes. Opioid. Opioid, yeah, very common. So morphine, oxycodone, all cause AMS, yes. Another medication. Barbiturate. So if you have barbiturate, they cause phenobarbital. Yes, very enthusiastic, yes.
Insulin.
Insulin, yes, it's very important. If a patient comes in with confusion, your eye should say is diabetes medication. Yeah, is diabetes medication, because its emergency management is give glucose. I will tell you, we have in my emergency room, I work in emergency room, many different manifestations of hypoglycemia. I have seen patient sleepy, seen patient angry. One patient, he is with my ER boss, he take his leg, he kick him in the chest, hypoglycemia, very low hypoglycemia. I have seen people looks like stroke from hypoglycemia. So one important principle is consider low blood sugar first minute. Patient comes in emergency room, first minute, check finger stick right away. Insulin and all diabetes medication. Any other idea? What's that? Oh, lithium, yes, lithium. So it's a psychiatric disease. The patient has psychiatric. In fact, most psychiatric medication has some AMS, some somnolence, sleepiness as a side effect. So you must also say it's difficult because if patient has psychiatric disease, maybe AMS is disease, maybe AMS is medication. Either differential, two ideas. Okay. Any other idea? There's a very good list, but if you think benzodiazepine, tranquilizer, opiate, psychiatric medication like lithium, diabetes medication, that's a very good list. This is common. Any other idea people have? Any other experience people have seen? Cause confusion, medication. Just be careful, because if you find medication, then patient does not need CT, does not need LP, does not need neurology consultation, nothing. Then usually, if you have good clinical suspicion, or you maybe can do measurement, if you do measure urine test or blood test for the drug, then you can make that diagnosis. Okay. So we will stop here because this halfway, because first concept, I will do review, then we'll do more. First concept, if patient has acute problem, doctor has to be 100% sure it is acute, because maybe dementia, chronic problem, or maybe psychiatric. Maybe acute psychiatric, maybe chronic psychiatric. But if you think diagnosis is delirium, then your brain must do 4 categories. It's the MIST or KIRI. MIST. Say, is metabolic problem, then must do blood test and ABG sometimes. Infection problem, if they have fever or leukocytosis, then inside brain, especially young patient, outside brain, especially old patient. All problem inside, tumor, stroke, bleeding, you must do with the imaging test, and then illegal drug, excess alcohol, and then our medications. We made very good lists. You should remember a list in your mind, which drugs may cause altered mental status, because it's important. Very common explanation in the algorithm. Okay, so if you know this, then we must say, what is emergency management? If a patient comes to emergency room, let me take here. Then we say, if patient comes in emergency room, they come in on gurney, patient comes in AMS, sleepy, eyes are closed. Say AMS, you must, what will you do in emergency room? What is first step you do in emergency room? First step. You must do vital sign, ABC, so ABC always. If ABC is okay, vital signs are okay, then what do we check first?
Parasite.
You said parasite? Yes. A good doctor, yes. You said parasite? Oh, we say English, pronator drift? Yeah, but he's on bed. He's on gurney, sleepy. Says sleepy. He can't do. So what do we check first? Before pupil, glucose. First thing, because only 1 minute, if every minute brain does not have glucose, is emergency. So first thing check is glucose. Some doctor says check glucose. Some doctor or some book says just give glucose. Either, it's your choice. I think it's okay. You have 1 minute, check finger stick very, very quick. And so I say number one, check glucose. Oh, number one, sorry, ABC. ABC always. Airway, breathing, circulation, vital signs. And you can, if you like, you can do GCS also. Like GCS sometimes is important. Number two, yes, is check glucose. That you give, or IV glucose. Check glucose or give glucose. Number three, it's different. Some places different than other. If patient has opiate or patient has pain medication, which medicine can we give immediately? For if they have oxycodone, morphine, other opiate pain medication, which is medication you can give? Yeah, so naloxone. That's it. You give antagonist. This one, some doctor does very early, some doctor does very late, plus minus. But naloxone must consider. Okay. Then we have. So this is first thing. Vital sign, GCS. Check glucose, maybe give naloxone if you have some suspicion. But then we must do exam on patient. We must do examination. Okay. So tell me now, what are important things in examination? Patient is lying on gurney. Patient is sleepy. What are important things we must do? It's like residents sleepy. What must we do early examination? Somebody said over there, I think veteran, which is quick exam. What do we look for? Pupil. So pupil is important. Pupil said because pupil gives idea about brainstem, and in AMS, first question is brainstem okay and cortex okay. So we do pupil exam. Please tell me, what are you looking for in pupil? What is the most important thing? You have flashlights, you look. What are you looking for? What thing? Yeah, anisocoria or difference. You want to see if it's asymmetric. So it's okay if the small pupil may be opiate. If it's different, no, asymmetry. Asymmetric. So one pupil looks like this, one pupil looks like this. What is problem? How come? How come one pupil is big, one pupil is small? One pupil with light constrict, one pupil with light no change. How come? What has happened? Yeah, herniation. Yeah, herniation. Some problem, usually something like this, typical. Some problem like this has rise in intracranial pressure. Then herniation is beginning. So temporal lobe is pushing on CN3, cranial nerve 3, pressure. So if you have asymmetry, then this is emergency. So you must then do CT quickly, maybe call neurosurgeon if there's an asymmetry. I will give a side story. Anybody know, this is a quiz, this is fun, not AMS. If patient, one medication sometimes we give can make one pupil very, very big. You know, maybe a patient has COPD or asthma, and then one pupil, you see patient, he's very happy, he is talking, he feels good, but one pupil huge, big pupil, other one small. How come? This is mystery, medical mystery. What? Hernia? Horner is possible, but this is big pupil, huge, 10 millimeter. Other one, Horner's is a little bit different, subtle difference.
Beta stimulant.
Yes. So this is, maybe Dr. O'Hay, you have ever seen if nebulizer mask goes one direction. Sometimes we put masks on patient. But if it goes like this, then all beta agonists go in one eye. So one eye becomes huge. Patient is very happy. Patient looking, talking, feels fine, but one eye very, very big. Because I work at Veteran Hospital in UC at San Francisco, many old smokers, so many COPD. So we give nebulizer, but if nebulizer shoots up into eye, then eye becomes very big. But patient has no AMS. This AMS plus pupil is problem. No AMS is okay. So you must remember. So then we do physical exam. We must do cranial nerves, and then we must do general physical exam and general neurologic exam. So general neurologic exam, we are trying to find this, but also evidence of metabolic. So we said before asterixis. How do we give patient instruction for asterixis? What do we tell them? How do you tell patient asterixis? Anybody know? Has anybody seen asterixis flapping? Anybody has seen or no? No? Anybody here has seen? Or you've seen? Yes. What does it look like? Yes. Yeah. Ah, very good. It's nice. It's sometimes very little. Just some patient is like this. Some patient very severe. Some patient though you have to watch careful. Just this because no. Show your hand. Everyone put hand out. Just wait. The two hand. Look, two hand. Little bit shake, right? Little bit. Everybody has little shake, but you want this. If it's this or falling, then that's asterixis. It's not tremor. Because everybody has little tremor. It's very hard. If you stay 30 minutes, it's very hard. It's very hard. But if patient will have little tremor. So physical exam, look for this. Physical exam signs for meningitis. What are physical exam signs for meningitis? What's that? Koenig and Brzezinski. Interesting. Koenig and Brzezinski sign is a historic, 100-year-old sign. But in JAMA did rational clinical exam, maybe in late 1990. And they say evidence base for Koenig and Brzezinski is so-so. But they like one sign from Japan. Which is their favorite sign from Japan? Jolt. Jolt is Japan export. The Japanese physical exam sign exported to the whole world. The Jolt sign. And Jolt sign is difficult to do. Has anybody ever done Jolt sign? Does anyone know how to do Jolt sign? No. I don't know proper mechanism. Maybe Dr. Dhaliwal, I think it's take head turn twice, right? 2 times, or Dr. Ohe, is that right? I think it's take head and turn 2 times, jolt sign.
It's like 2 or 3 times just
Yeah, but only one direction or back forth?
back forth だよね。同じ方向じゃないの？
Right to left.
I think it's back forth.
Yeah, maybe back and forth. So it's very interesting. Jolt sign, only one paper, 1991, from Japan. One paper, maybe 20 patients, and it's positive. So you take head and turn 1, 2, and then say, does it hurt? It hurts. You should try. Do your head now. Everyone do your head. 2. Quick, 1, 2. It hurts. A little bit uncomfortable. It's a little bit uncomfortable. But if patient has pain, it's positive jolt sign. And some positive correlation with meningitis. But never any other paper. Only one paper, 1991. So some people for meningitis do jolt sign. Then you do neck stiffness also is other possibility. But you must know, because I think in Japan it's very popular. In US, jolt sign became popular after JAMA article. JAMA had article, then JAMA article says Koenig is no good, Brzezinski no good. They said, but maybe jolt, and then it became popular. It's like internet sensation. It became popular. Everybody started using it. So you do structural exam for structure is cranial nerves. Most important is cranial nerve. If brainstem has problem, that's serious problem. So if cranial nerve problem is present, that means brainstem is not working. If brainstem is not working, it's very serious problem. So we have to do full physical exam, but focus on this inclusion. Now, when there's textbook shows 2 different types of problem. If patient is going into deep coma. Coma means no response. GCS very low, no response. Then there's 2 different type of motion with arms. So patient is on gurney, becoming sleepy. Then there's 2 positions that happen, and you must practice, you must know this. So one is if CNS damage, CNS pressure, CNS hemorrhage, herniation, if pressure is rising, or cortex loses function, then patient can have this. So do this one. Everybody does this. This is called discordicate posture. Discordicate posture means cortex has some damage, some problem. But which is worse? After this, what happens next? Everybody know next? Decerebrate. This is like exercise class, no? Exercise or dance class. Decorticate. But if pressure keeps rising, brainstem more and more pressure, then decerebrate. Arm goes like this. This is very severe sign. Then very difficult to recover patient. So some emergency sign is if you see asymmetric pupil, and then other emergency sign is if you have this, maybe patient's having seizure, having bleeding, and then arm goes like this. This is emergency sign also. Needs CT quickly, needs neurosurgery very quickly for confusion to help. And those are major emergencies. Then AMS has many other things. This is emergency stuff. Glucose, naloxone, cranial nerve, and then make sure no problem going into coma. If patient goes to coma has same differential. Coma has same differential for AMS, but it is more serious, has higher level of emergency. So you must think about this when you go through. Okay, so now you have assignment. We'll spend 2 minutes. We're almost finished. Turn to your neighbor. Tell neighbor something new you learned today, something new from lecture today. So each one says something I learned new. So you talk. Something new you learned today. Nice. Okay, so we'll do summary 5 minutes, then we're finished. So please tell me something new you learned today, something that is new information for you today. So something new today. New concept. Missed. Okay, so 4 category concept. So very good. Something new. What's that?
Beta stimulator.
Beta stimulator, yes. It's funny if it happens, yes. But then it's okay. There's no emergency. Yes.
And English.
And English. Very good English, yes. You will learn, I will teach for 4 days. You will also learn some English from me, yes. And I will learn Japanese, like Kiri. Something you learn. Yes, very popular in Japan, but also the rest of the world. Yes. Other ideas, some things you learned. Yes.
We don't use
Naloxone. Which medication? Yeah, no, it's usually not too. Even in US, usually not. But always must think about. Glucose 100%. Must check glucose 100%. Naloxone is not 100%, but you should think 100%. So maybe, not every patient needs, but you should just remember it. So good points. Other things you have learned? Back table. Yes.
I have an example. Some doctors take naloxone even if the patient doesn't have a smoking.
Yes. This is in United States emergency room. I was saying they say no matter what. They give glucose, give naloxone, no checking. Other doctor says, I will check pupil, I will check medication, and then I will give naloxone. So I think different style, different practice style. Yes. Other things you may learn? On the back, any new concepts? Something new?
I have a question. Do you use flumazenil?
Flumazenil, yes. If a patient has benzodiazepine, then flumazenil you can give. I think in emergency room, naloxone is very easy. Flumazenil, sometimes they have to get from the pharmacy. Not so frequent. They have. But yeah, same concept. Other ideas maybe you learn? Something new. Check your notes. What's new idea in your notes? Everybody likes naloxone, very popular. Okay, other ideas, some new idea you learned. Yeah, good. So cortex and then cerebrum. It's like exercise, cortex, cerebrum. But you must watch out. Yes, it's a dangerous sign if you see something new you have learned. Non-CNS. Yes. So elderly, more typical non-CNS. Young person confusion with infection usually inside a CNS. So it's very good distinction. Okay. So make sure, we will do lecture every day, we do lecture each day. Make sure you, after you take notes, you review same day. Because if you say I will review tomorrow, nobody review tomorrow. So find 5 minutes today, afternoon, evening, check your notes. And when you do emergency room and you have AMS patient, or you do hospital and you have AMS patient, then check these notes so you have some practice. Okay. Any question for me? Okay, we will finish 10 minutes early, so we'll finish now. Thank you very much. Now, tomorrow we'll do grand round 7:45, Luis-san?
7:30.
7:30.
Sorry, yeah.
7:30. I always forget. Yeah, 7:30. Okay.